Today we're here talking to Chris Spencer, the Chief Executive Officer of EMIS Group, the healthcare IT supplier.
Morning, thank you for having me. I'm good form, thanks.
More than welcome. Right, we'll crack on. The NHS's 5-year plan that was published in October underlines the need for a converged healthcare system. We've been down this road before, haven't we, with the National Programme for IT, etc. What's changed this time?
I suppose there's a couple of things, aren't there, really? One is, if you like, the National Programme for IT tried to do the right thing in the wrong way. So it was sort of integration or convergence in the sense of the hedgehog was integrated or converged with the tyre. So it was very top down, didn't engage with users, didn't engage with clinicians, and crucially, this is the thing, had lots of money to do it with. I think the big change now is there is no more money, there is no more ability to say, let's do it in due course, we've got to do it now. And we've not just got to do it now because the money's run out, but effectively because, well, ageing population, long-term conditions, we're getting older, we're having more long-term conditions, we've had another 10 years of waste during that period. Got to change.
Right. But at the moment we've got NHS budgets under enormous pressure. The government's been looking to strip out something like 20%, I think it's about 15 to 20 billion pounds out of the whole NHS budget by the end of this year.
Yeah.
Can you explain to our viewers how a private sector company can generate profits against such a backcloth of cost savings and cost cuts? Sure.
I think it's about faster, better, cheaper care, which is really about project management. Think about it this way. If you have a kitchen done, you're essentially going to say, what happens normally if you don't have a project manager? The first thing will happen is the electrician turns up at the wrong time. They then go away because there was nothing for them to do. That's a waste. When they do come back, it'll be 3 weeks afterwards, so you've had a delay. That's a waste. And they'll then need to go off and buy some stuff because they didn't have that in the first place. What's that got to do with healthcare, you're going to say? Think about that in the context of somebody who suffers from diabetes. They probably don't know they've got diabetes. They need to be told they've got diabetes to avoid it getting worse. They need it project managing. And if it's not project managed, then there'll be waste. So you produce faster, better, cheaper healthcare by having the information given to the right people at the right time, all but only that information given to them. And the earlier you give them that information, the better. And that'll then mean for every £1 or £10 you spend earlier on, you'll save hundreds, thousands, if not tens of £1,000s later on. And that's how you end up with faster, better, cheaper healthcare.
I suppose to a certain degree as well, it's freeing up time for GPs as well. Their time is under massive strain.
Absolutely.
And so the whole system helps them focus on giving direct care and ultimately better care.
Well, it's certainly about that, and it's also about utilising those scarce resources and, if you like, pushing some of that work downwards into other parts of the system and upwards into other areas of the system as well. And the whole of the 5-year forward view, for example, is about different ways of working. Federated working, say, for GPs all working together, having folks who are working in a different way with GPs and community, GPs helping run hospitals, sometimes hospitals helping run GPs. That melding of those various aspects means you get the right person doing the right job. Exactly your point, making sure that you're playing to their strengths and not having them doing lots of administrative work. You know, really great quote I had a while ago from somebody who was saying to me, what's the difference between a hospital and a pharmacy? What do pharmacists do better than hospitals? The answer? Parking. You've actually got the access to be able to go to the pharmacist rather than having the difficulty of trying to get into the acute space, spending a fortune, etc. So what you're going to do, you hopefully ought to go to the pharmacist, head off this illness at the pass and never need to go to the hospital, hopefully.
Okay, thanks Chris, that's fascinating stuff. Let's also return to October, and we had the last GP SOC contract that came through, and that's the GP System of Choice contract framework. And there seems to be a massive transition between the previous regime, where massive integrators were part of that and SMEs were largely ignored. and now there's been a real shift. If you look at the list of which your company is clearly on, almost all the companies there would be classed as SMEs. Can you explain why that trend has come about and what are the benefits to EMIS and to the wider SME market?
I think there's been common sense prevailing. We've mentioned the National Programme for IT, which did some good stuff, but it also spent a lot of time, wasted a lot of money in the billions. That was done by that top-down approach, taking on integrators who then brought in many, many subs. So the reality was, why not engage with the people who are already doing the great stuff, the stuff for which English, particularly UK, IT is already world renowned. Why not get those people to do it directly? And I think that's what it is. If you like, there's been a breakout of common sense. And also remember, it's back to what I was saying earlier on, there isn't the money to be spending on too many middlemen. So you strip that out, you go to this more localized approach, the people who are actually doing the job, and you trust them to get on with it for you.
Do you think that there's also an element of winning trust amongst the populace because they will be less familiar with companies like yourselves? Is it a case of getting your name out there, getting into the mainstream press possibly, and showing you're a safe pair of hands? Sure,
I mean that's one of the reasons why we IPO'd in the first place, was actually to deal with the transparency point you're talking about. Having a very private company at that time up in Yorkshire with 30-odd million patient records was a sort of slightly strange, jarring situation. So we IPO'd in 2010. Moving on now, we're still probably the biggest little company that nobody's ever heard of, but they know a lot of the brands. So if they go in, they talk to the people they trust. You say to any GP, have you heard of EMIS? They will know the brand. If you talk to, well, 18 million people a month, they'll know patient.co.uk. Right. So they know one of our brands, and gradually that's building up that trust. But you're absolutely right. It's trust both ways. We have to be absolutely fiduciaries of that data. I've mentioned, 39 million patient records there. That's 53% of all systems in GP land. Huge amount of responsibility, and hopefully that plays through and people understand that.
Chris, you make it sound almost as if this is a once in a lifetime opportunity for this area. Do you see it as a once in a lifetime opportunity?
I think we're in a sea change. We've got a wave following that theme that we can jump on now. If we don't, I fear for the NHS. I really do. And it's such a key part of our country, both culturally and politically. We've got to get on top of that. But there will be lots of things which happen after this. Remember, the NHS is 1.6 million people. If you start to bring it in with things like Devo Mank and bring in folks from social care as well, it's an even larger amount of people. It's an opportunity we've got to take now. It involves so many people, and that's where the change management will be, and that's where the challenges will be. They'll last us for quite a while to come.
Is there any, do you foresee any upset in the system with the general election just on the horizon? Is that something that concerns you at all?
Always a general election is going to be an issue for any sort of business because it introduces uncertainties, but less so perhaps than usual because of the drivers I've been talking about. We do have, for all of the parties, a common understanding that there is a limited amount of money and there is an increasing amount of demand, particularly from older folks with long-term conditions. And across all of the parties is an understanding that the way to deal with that is through integration of care. And we absolutely see ourselves as being at the heart of that integrated care agenda.
This is an increasingly competitive environment, but with so many SMEs now on the official healthcare NHS list, companies like Northgate and CSC, Civica and TPP, they've been around for a long, long time, much as yourselves have. We've also seen companies go off the market into private equity hands, such as Advanced Computer Software recently, and there's names Ideagen, Servelec that are on the market and accessible to private investors. How do you see the competitive environment in the UK? And do you think there's a danger that overseas companies will start eyeing the opportunities, companies like McKesson, maybe Cerner, come from abroad and start taking a bigger piece of that pie?
Okay, I suppose there's a couple of things. Let me start with some figures because I think this illustrates and really emphasises the point. If we look at our market shares across a whole variety of areas, primary care 53%, we move across in community pharmacy 35%, into hospital pharmacy 31%, and into A&E 41%. Sorry, I mixed those two up. It's actually pharmacy 31, sorry, 41, and A&E 31. And then across out into diabetic retinopathy, 80% of the market share. So that's a huge amount of market penetration, and it's ubiquitous. Effectively, it's throughout the whole of the healthcare systems in the main pillars of those areas, with growing elements in CCMH, community child mental health, and also, of course, that newly emerging market, patient access, and I mentioned patient.co.uk earlier on. So we have that enormous amount of data that we were talking about earlier on, with which we're trusted on a day-to-day basis. Most of that comes in its richest form from primary care. So if you contrast that with a lot of our competitors, not just in the UK market, but also in the US market, they may well be in one or two of those areas, but not in all of those areas. So that existence in all of those areas, that ability to mobilize that data in a very careful and governance-driven way, is extremely important, very crucial to driving this forward. And the final point, I suspect, on the US approach, remember the way that the US system works. Typically, it's top-down, a bit like the national programme, in the sense that in this case, the top is the acute space. The information is stored in the acute space, it's generated in the acute space, and then it flows down into the community in the primary care area. That's the background for folks like Cerner and McKesson and Epic. That's how they see the world. Our world, since the formation of the NHS, is about the other way up, about it starting off with primary care, particularly list-based primary care, and pushing upwards. That's a strong position to be in. It's a position that we don't take for granted, but it's a position that we do enjoy and we intend to work on and push forward for the benefit of healthcare and, of course, for our benefit of our investors.
So that acts as a barrier to entry.
Absolutely right. Yeah. Absolutely right. That and as I've said, the strong position in each of those areas as well. So it's the data plus the ubiquitousness as well.
Sure. Okay, thank you. One of the main parts of your business has been EMIS Web, and that's the website that drives GPs and controls GPs and brings patients together. But you've also grown quite rapidly into community pharmacies, as you've been talking about, through your RX system.
Yeah.
The idea of expanding more into community mental health, children's mental health, and so on, hospital pharmacies, A&E.
Yeah.
Can you just explain where the crossover points are here, and what EMIS can do to bring those areas together?
Sure. Let me give you an example, because if we talk about stats, it depersonalises, it's done that. Let's take a guy called Abdul. It's not his real name, but he's based on a real person. Abdul was a patient of local federation in the London area, and Abdul found difficulty going to his GP. Largely because he didn't want to go to his GP. It was a bit of a pain. They didn't open at times when they wanted to open. He went once or twice, and they found out actually that his blood glucose level was wrong. But they phoned him up and said, oh, we'd like to give you some tests. He didn't come back to them. He went in one or two times into A&E. A&E did similar sorts of tests. They didn't notice that either. He went in for a whole variety of reasons to his pharmacy, his high street pharmacy. He said, I keep getting lots of, really thirsty all the time, really lethargic. And they said to him, well, maybe you ought to go and see your GP, because that sounds as though it might be diabetes. And he just ignored it and didn't do that. And finally, he developed a leg ulcer. And the community nurse came along and addressed that. Well, this is a relatively young person, mid-30s. You don't have leg ulcers which continue for an extended period if effectively there isn't something more deep-seated wrong for you. And she eventually referred that through. Let's rerun that, because all of that is to do with individual pockets of care. Now, if Abdul had had a situation whereby either initially he'd gone onto patient.co.uk and said, lethargy, I'm basically a little bit heavy, I'm probably obese, or even morbidly obese. Maybe he'd taken his blood pressure and uploaded it using a device of some sort, and he'd then been told, and thirst as well, come on, you really, really do need to go to your GP, or if that won't work, you're any. Well, if the GP had had a means of quickly reaching out to him, actually telling him on his mobile device, which, by the way, we all have, don't we? Rather than thinking, oh, well, something will happen, pushing it out to him. What if the A&E department had had access to the GP's records? What if the pharmacy had had access to the GP's records? And what, finally, if the community nurse had had access to all those records? Now, the sad bit about this story, the really sad bit about this story, is that went on for 7 years. And during those 7 years, there was an impairment of Abdul's renal function, so that effectively, he's now never going to get better. Dialysis come in, effectively he may well die. That's what integrated care can do, that's what it can deliver, and that's when there's a failure, those are the catastrophic consequences. And it's not just about Abdul and about his life, it's the lives of people around him, and of course it's a huge amount of money wasted as a consequence of that.
Yes, but we talked earlier about the almost project managed.
Yeah.
That has to come from the GP, but is there the concept of confliction between, well, who is managing? Sometimes pharmacies will manage people's healthcare, sometimes it's a GP.
Yeah.
Is there potential for conflict there?
I don't think it's conflict so long as you're working, if you like, in professional teams. I think if you have a team of people who professionally can understand and work in virtual teams together, that's what they do all day long. You know, if you go into a hospital, a team pulls together to do a particular thing for you and then it dissipates again. It's not a matter of conflict because they're all rooted in the same thing. They want to share the record, they want to share the information, and what they want to do above all is save Abdul's life and indeed, increasingly, stop Abdul getting ill in the first place.
Yes. Chris, that's great. Thank you very much indeed. I hope you enjoyed that. All the best.
Thanks.
All good?
Okay, didn't do much talking to camera.